Good morning, everyone. Today's topic for presentation is biological aspects of dental implants, a hard tissue interface. Dental implant is an artificial titanium fixture that is placed surgically into the jawbone to substitute a missing tooth and its roots. It is one of the fastest growing treatment modalities in dentistry. This particular topic is dealt under two headings, that is hard tissue interface and a soft tissue interface. And today I'll be dealing with hard tissue interface, which is a fundamental requirement and an essential component of an implant success. So what do you mean by hard tissue interface? Hard tissue interface is implant and bone connection. So the primary goal of this installation is to achieve and to maintain bone to implant connection, which is termed as osseointegration. This particular terminology was first coined by Per Ingvar Breinemark in 1969, who happened to be a Swiss anatomist. While studying blood circulation in bone, he observed this phenomenon, and this refers to the process that takes place between living bone tissue and the surface of implant. This terminology was described in the literature by many authors, and important ones are Albertson in 1981 describes it as histologically direct structural and functional connection of ordered living bone and the surface of load-bearing implant without intervening soft tissues. Schroeder describes it as clinical ankylosis of implant bone interface, which it names it as functional ankylosis. And clinically, it describes it as asymptomatic rigid fixation of an alloplastic material, it's an implant in bone with the ability to withstand occlusal forces. American Academy of Implant Dentistry defined osseointegration as contact established without interposition of non-bone tissue between normal remodeled bone and an implant, entailing a sustained transfer and distribution of load from the implant to and with in the bone tissue. Bone implant interface is studied under two basic theories, that is osseointegration given by Breinemark, that is direct connection of bone and implant, and fibro-osseous integration given by Linkov and Weiss. Fibro-osseous integration or fibrointegration is a tissue to implant contact with interposition of healthy dense collagenous tissue between implant and bone. So as you see in the first picture, there is an orange line which represents a fibrous tissue, that is a connective tissue, presence of connective tissue between the implant and bone, which is absent in osseointegrated surface in the last picture. And along with this, collagen fibers function similarly to Sharpie's fibers found in natural dentition. The fibers are arranged irregularly parallel to the implant body. When the forces are applied, they are not transferred through these fibers. Coming to mechanism of osseointegration, so bone healing process takes place either by primary or secondary bone healing. So in primary bone healing, there is well organized bone formation with minimal granulation tissue formation, which is an ideal type of bone healing for osseointegration to occur. Whereas secondary bone healing, they may have granulation tissue formation and infection at the site of prolonging the healing period, where the fibrous cartilage is sometimes formed instead of bone. So which is an ideal undesirable type of bone healing for osseointegration to occur. So what happens when the osteotomy is prepared at the site of to place an implant? So the blood between the fixture and the bone is filled, and then it gets clotted, and then the clot organization takes place where the inflammatory cells like polymorphonuclear leukocytes and phagocytic cells like macrophages, they get into the surface, and procallus formation is the next step where there will be more deputation of fibroblasts which appear and later converts to callus, where fibroblasts, they release more of, they differentiate into osteoblasts, and then remodeling of bone takes place and organizes. So initial bone healing has got some sequence of events in the implant osteotomy site where the inflammatory reaction, bone resorption occurs, the release of growth factors, and attraction of chemotaxis of osteoprogenitor cells to the site, and differentiation of these osteoprogenitor cells into osteoblasts, leading to bone formation at the implant site or implant surface. Along with this, extracellular matrix proteins such as osteocalcin, uh, which modulate the hydroxyapatite crystal growth, helps in mineralization process. In specific conditions, the optimal bone formation must be maintained at the healing site to achieve this osseointegration. Along with this, immobilization of an implant must be maintained during the early post-insertion healing for bone formation at the surface. Moderate inflammation or movement above a certain threshold is detrimental and may lead to implant failure. If micromovements exceed 115 microns, the movement will impair the differentiation of osteoblasts and fibrous scar tissue will form between the bone and implant surface. Coming to biological process of integration, which is studied by Breinemark, is divided into three phases: osteophilic phase, osteoconductive phase, and osteoadaptive phase. Osteophilic phase is the first phase, where the blood clot formation and inflammatory cell infiltration, neovascularization at third day. What do you mean by neovascularization? Neovascularization is nothing but the new blood vessel formations at the site, and ossification begins during the first week and the phase lasts for 1 month. So during this particular phase, the cells which appear into the picture is polymorphonuclear leukocytes, then you have macrophages, fibroblasts appear. Osteoconductive phase is the second phase where the woven bone formation uh, starts occurring, and which is again later replaced by lamellar bone formation. In this particular phase, there will be osteoid formation and non-trabecular surfaces, and neovascularization and callus formation occurs, and this particular phase lasts for 4 months. Osteoadaptive phase is the last phase where the balance remodeling occurs. The woven bone, thickened woven bone responds to the uh, load transferred through the implant, and there will be reorientation of vascular pattern which may be seen. Stages of osseointegration is named as surface modeling and remodeling maturation by Carl Misch, which he divides into various stages. Stage 1 is woven callus formation, where 0 to 6 weeks, and the stage 2 lamellar compaction phase, where it lasts for 6 to 18 weeks. Remodeling and maturation phase again divides into two phases, stage 3 and stage 4. Stage 2 and stage 3 will have an overlap between 6 to 18 weeks. And stage 3 interface remodeling. Stage 4 he names it as compact maturation phase, which lasts from 18 to 54 weeks. Incorporation of oven bone formation. The biomechanical capacity of oven bone is poor, and the new bone formation adjacent to an implant follows a specific sequence of events, with oven bone forming quickly in the gap, and it grows faster, 100 microns per day, and in all directions, and it is characterized by random orientation of its collagen fibers, high cellularity, and limited degree of mineralization. And after several months, oven bone is progressively replaced by lamellar bone with organized parallel layers of collagen fibers and dense mineralization. Contrary to the fast-growing woven bone, lamellar bone formation occurs at a slow pace, only a few microns per day. Ultimately, after 18 months of healing, a steady state of is reached where lamellar bone is continuously resolved and replaced. Bone remodeling and function clinically, uh, primary stability and secondary stability of an implant are the critical for a successful implant. The primary stability is achieved at the time of surgical placement, depends on the implant geometry, that is macro design, which is the classification of implants, that is endosseous implants, blade implants, pins, root forms, disc-like implants, and screw-shaped implants, tapered implants, subperiosteal implants, and transmandibular implants. So, type of implant is an important criteria for establishing the primary stability. Along with this, there is quality and quantity of bone available for implant anchorage at the specific site. Secondary stability, which is achieved over time with healing, depends on the implant surface microdesign, which is an additive process or a subtractive process. Additive process involves the surface alterations, that is, addition of hydroxyapatite crystals over the surface, and deletion is again uh, polishing the surface of implant, removing the surface characteristics. So, along with this, quality and quantity of adjacent bone, which will determine the percentage of contact between implant and bone. The factors influencing osseointegration have been classified into implant-related factors, surgical factors, and patient-related factors. So, implant-related factors involve more of material properties, surface characteristics of the materials, etc. And surgical characteristics, the type of surgery, whether it is a transmucosal attachment or single stage surgery, second stage surgery, so type of surgical procedure which is involved. And the last one, that is patient related factors, involve systemic conditions along with the osseous considerations. So the most important thing in this particular lecture is the osseointegration and fibroosseous integration, and various phases of um, the integration between